Good.
I think we can start. Good morning, afternoon. My name is Gabriel Ruiz. I'm one of the trauma surgeons at the Ryder Trauma Center in Miami. Weather down here has been kind of bad, very humid and lots of rain lately. It's nice to see you all, see so much participation. Let's get started. I have no disclosures to make for this presentation, no any financial interest to disclose. And let's just dive into the case itself. This is a very young female who was involved in a motor vehicle collision. She was a restrained driver in a high-speed accident in the highway. Rescue said that they estimated that she was traveling around between 60 to 70 miles per hour. She was the only occupant of the vehicle, and the crash was a frontal crash with lots of intrusion of the steering wheel column into the car. She was tachycardic and normotensive during transport, and when she arrived into the trauma center around 9:20 p.m., she was very agitated. She was intoxicated with alcohol, very difficult to control. So we proceeded to intubate her because of combative behavior. Although she was voicing and her voice seemed normal, she was actually screaming, but she got intubated because she had combative behavior. We continued doing our assessment, and we found that she had decreased breath sounds on the right side and significant chest deformity. We could see that the chest was asymmetric, with being the right chest having kind of crackles on palpation, not really crepitus, but the ribs could be felt that there were fracture on palpation, and she received a tube thoracostomy. The tube thoracostomy drained a good amount of air and about 150 cc's of blood that looked dark, but then it slowed down about at 200 cc's in the first half an hour, and that was it. It just trickled from there on. After we placed the chest tube, we started having the first set of vital signs, and she was tachycardic and normotensive. On the initial admission, when she came in before she was intubated, her GCS was 13, accounting for the fact that she was very confused and was not following commands, but it was not consistent. We kind of attributed her GCS to be a 13, anywhere between 13 and 14. Obviously, after intubation, she was a 3T. Significant injuries on exposure. She had a deformity on the right arm, the forearm, the left wrist, and she has a small, maybe a couple of centimeter facial laceration, no active bleeding. The fractures were not open. Got a chest x-ray, and you can see the picture of the x-ray of the patient with the tube thoracostomy on the right side. Significant amount of infiltrates on both sides. Multiple rib fractures on the right side, especially in the upper ribs. You can appreciate on the posterior ribs and the anterior ribs. Some rib fractures on the left side, 2 or 3 rib fractures on the left side. Pulmonary contusions, mostly on the right side. Trace right side in pneumothorax is very difficult to see on this projection. And pneumomediastinum, as you can see, especially on the right side, you can see a lucency of air around the right ventricle and a little bit of air on the left ventricle, just at the spot where the aorta takes off. The patient was right main stem intubated. We pulled out the tube a couple of centimeters. I don't do an x-ray to follow this up, usually. I just pull out the ET tube and recheck the breath sounds. So we did. And at this time, the output from that chest tube was minimal. The pelvis x-ray, there was nothing significant on her pelvis x-ray. There were no fractures. There was no diastasis of the symphysis pubis. And we did a FAST, and the FAST showed a little bit amount of fluid in the right upper quadrant. But what was important and was significant on this patient was that there was a really large pericardial effusion. And you can see a picture of it the right ventricle on top on your picture, surrounded by fluid and kind of squeezed by the amount of fluid, the amount of blood. She had some early tamponade physiology, and that picture that we teach our residents and our fellows as the little man jumping on a trampoline, which is the right ventricle. I have a recording of this, which I will show you later. So basically at this point, we have a patient that was tachycardic, had free fluid in the right upper quadrant, a significant amount of pericardial effusion associated to severe blunt trauma of the chest, one extremity fracture, no hypotension. Her blood pressure at this point was 105, 106. She's a young lady. And the ultrasound showed some early tamponade physiology. So my first question, Valeria, if you can put us the first management decision point on this patient. And I put some other options, some options here. What are you going to do with this patient? Are you going to stay in the trauma bay, transfuse some blood products, and reevaluate the patient? Are you going to go to the operating room for an exploratory laparotomy? Will you send this patient to radiology for a PET-CT scan? Go to the operating room for a median sternotomy? Perform an ultrasound-guided percutaneous drainage of the pericardium? Go to the operating room and perform a pericardial window? Perform a left thoracotomy in the operating room, in the trauma bay? There's probably more than one option among those answers there. You can choose more than one and work out in your own algorithm. I'm going to give you a couple of minutes. Gary, I'm going to ask you to see if there's anyone in the audience that doesn't have the ability to vote who could tell us what that person would do, and if there's anyone else that has any different opinion on besides these few options to give us an idea and some rationale. And I'm going to give you the next 2 or 3 minutes to go through the audience to see if there's anyone else that would like to speak. Here, thank you.
Okay, if I recall correctly, I'm sorry, go ahead, please. Dr. Frisbee?
Yeah, I've got a question. What's the lateral chest look like?
You mean the chest x-ray?
Yeah. You didn't, it's got crushed. She's got crushed. What's that sternum look like?
Well, that's actually a very, very good question. On palpation, we felt that there were crepitus, and you could feel the bones cracking on the sternum in the manubrium and along the right side of the ribs. I didn't shoot a lateral X-ray, but on clinical exam, it was obvious that she had a significant impact on the sternum, and the sternum was fractured. That's a good question.
Thanks.
Okay, Dr. Ruiz, if I'm not mistaken, everyone can interact with that except Dr. Calais and Dr. Fraga. Is that correct, Dr. Calais and Dr. Fraga? You're on Polycom Systems?
What?
Yes, sir. Are you you know what? Today you're on a laptop.
Yes.
Forgive me. And
Yes, I'm a laptop.
Okay, very good. And you, Dr. Fraga, are you able to interact with the poll? You're muted, sir. You're still muted. There we go. Good.
Yes. I am from my laptop.
Okay, very good. Then that should be, everyone should be able to interact.
All right, so let's see the answers and then we can have a little bit of discussion on the answers. Valeria, if you can show us what the answers were. All right, so about a fifth of the people will want to transfuse this patient. About 10%, 15% of them are gonna go to the operating room and do an exploratory laparotomy. Interestingly enough, 1/3 of the audience will want to go to a CT scan, and I wonder if those who want to go to CT scan will want to go now or would like to do something before going to the CT scan. 10% would do either a percutaneous ultrasound-guided drainage or go to the operating room for a median sternotomy. The biggest answer is go to the operating room for a pericardial window, and some of them think that we might need to do a left thoracotomy. And the complexity of this is that there's not just one answer, but rather a series of the steps that I think we should take in order to take this patient. I personally will not just send the patient to the CT scan, to be honest with you. Probably I would get ready to start transfusing the patient, maybe start calling on my MTP to get my lab started on an MTP. I would definitely take the patient to the operating room. And what I would do in the operating room is a stepwise approach to get to this patient. And Valeria, if you can close and then I continue with the presentation, maybe we can go around the audience after the next slide. This is what I decided to do. To me, it was clear that the management of these patients should be done in the operating room. And the sequence in which I do this, usually when I find patients that have pericardial effusion and have polytrauma in different cavities, is I start with a laparotomy. What we found was that she had a tiny right lobe liver laceration, a grade 1. Just the bobby was enough to control it. A very little amount of fluid inside the abdomen. Very quick review. There was no retroperitoneal hematomas in any of the zones. If I don't see these, I drop everything in the abdomen immediately and I go to the pericardial window. As we were dissecting the pericardium, her blood pressure dropped into the 80s. Heart rate went into the 130s. And as soon as we opened the pericardium, a very large and forceful jet of blood came out of the pericardial cavity. About 150 cc's of blood immediately after we opened the pericardium. This normalized the blood pressure of the patient. And at this point, the blood pressure was around 110. Heart rate had gone down from 150s to 110s. There was this 150 cc's of blood that came out really forceful through the pericardium. There was still a little bit of blood coming out. So it was no doubt that this was a positive pericardial window. I don't know if we can maybe go through the room. Maybe someone can tell us if has any different ideas on how to approach a patient like this. Some of those that would want to go to the CT scan, I would like to hear at what point in the management of this patient going to the CT scan they would go and what's the reason. And I'm gonna leave Gary to help me out going around the audience to see.
Yes, sir. Campinas, Dr. Fraga, you have a comment, sir?
Can you hear?
Yes, sir. Loud and clear. Go ahead.
Okay. The option to go to CT is according to the stability of the patient. When the patient arrived at the emergency department, the systolic blood pressure was higher than 90, and the heart rate less than 120. It depends of the surgeon who is considered and evaluate the patient. If you have the CT available, because a whole bar CT can be useful for this patient to make other diagnoses and to help to treat the patient. But if the team think the patient is unstable, so patient needs to go direct to the operative room. And now you have a positive pericardial window. The patient is on operative room. I think you need to open the chest. Sternotomy, I think is the best option for this case.
Thank you, Dr. Fraga. Dover, Dr. Alex.
Hello. So I chose the option to go to the operating room with the pericardial window. Before that, I was going to give volume, maybe start with 500 cc normal saline bolus. As according to the presentation, the patient developed tamponade physiology. You know, the patient is tachycardic, so that's a sign of blunt cardiac injury. I haven't heard anything about any ST changes or any concerns that, you know, her perfusion may be affected. You're looking at this in a little bit of a different way. This patient, you know, has significant trauma to the right chest, deceleration injury. Although mediastinum is now widened in the chest x-ray, it could be concerning that, you know, there's something going on or some element of dissection. So now you're in the operating room, you did the pericardial window, you evacuated the blood. So going this route, next thing I would like to know is what's going on with the aorta. Maybe ask anesthesia to do an intra-op TEE. Other than that, other option would be, you know, if you didn't go this route, you know, you put the drain and then you evacuate the tamponade and then you get your scan if you have other concerns. But at this point, I would want to have an additional TEE.
Okay. Thank you, Dr. Alex. In Portland, Dr. Kassim, your comment, sir? You're muted, Dr. Kassim.
When the patient arrived in the emergency room, as a surgeon, I have to determine which cavity this patient is in danger of, which cavity pathology the patient is in danger of dying. So having determined the patient has pericardial effusion, I think this is one time I would go to the chest cavity as opposed to going to the abdomen, especially when the ultrasound showed only a very small amount of fluid in the abdomen. Because any type of pericardial effusion, and if the patient has significant amount of blood there, that is going to kill her very quickly if you don't attend to it. So I would go to that cavity first. Hence, I would go to the operating room, do a pericardial window, positive, median stenotomy, and then control the bleeding whichever way I can. That's what I would do. Regarding the aorta, I think, as I mentioned in the previous week or 2 weeks ago, you have the luxury of waiting it out for 24 hours at least to determine if there is any aortic injury. Because most patients who have aortic injury, that is a transaction and they usually die on the field. So I do have time to deal with that later on. Thank you.
Thank you very much. And you mentioned and touched on a really, really interesting point, and I'm actually very happy that you mentioned this. For those of you that would not approach the abdomen first, what approach would you take to do the pericardial window?
Sao Paulo, Dr. Calais? I'm sorry.
Yes. Yes. In these situations, I put that I start with a pericardial window. Sometimes here I can see people have a pericardial infusion that's physiological. So I have to open the chest and open not a pericard, not a hemopericardium, seeing only a fluid in pericardium. So in some situations, the patient is relatively stable. This patient is not too much stable because he has tachycardic and his blood is not too good. I believe that patients need to go to see what's happening in pericardium. In this situation, I start the procedure with a pericardial window, a subxiphoid pericardial window. And then if the blood, I can go to a sternotomy or can go a left anterior thoracotomy and control the hemorrhage and control the blood. If there is, I found not blood in the pericardium, I go to a laparotomy, continue to the laparotomy and treat the injuries in the abdomen. That's the way that I come here in these situations. I think that sometimes you have pericardial infusion that is not the core, not is for the trauma, is for physiological the people. Some people have some infusion in the pericardium. So sometimes you can make a thoracotomy. It can not be a therapeutic thoracotomy. So it may be danger for these patients with trauma. So in this situation, this patient is stable. I go to a pericardial. In this patient is unstable and I see pericardial infusion, I go to a left anterior thoracotomy. Here, I prefer to go to the left anterior thoracotomy because the problem was the materials that I have here. Okay, that's the way that I do.
Thank you very much. Gary, let me continue because I don't want to get run out of time. Okay. And I'm going to give you a little bit of the story of our story here at the Ryder Trauma Center. In 2011, if I remember well, we did a study, which was a case series of patients that had pericardial tamponade for various reasons, both blunt and penetrating trauma. And what we found was that those patients that remain stable and in which they have ceased the blood from coming out from the pericardial sac after copious irrigation, those patients actually could be observed without performing either a thoracotomy or a sternotomy, even in the presence of an initial positive pericardial window. And we've been doing this for quite some time. The study was published maybe about 9 years ago. Since then, there's been a few more series that have supported this fact. And this is what we did. We waited since the patient stabilized. We irrigated the pericardial sac with normal saline. The fluid started to clear up. We got about 200 cc's total of blood. And the fluid cleared up and no more blood was seen. By that time, I had set up the OR to perform a median sternotomy if I needed to, so we were ready. But we continued watching the patient. The patient remained with normal hemodynamics for the next 15, 20 minutes. Pericardial sac was open through the window. No blood was coming out. We decided to put a pericardial drain, close the abdomen, and observe the patient in the ICU. Before that, we decided to CT scan the patient to complete the workup because, as Alex mentioned, there might be other structures that might be compromised. Of note, I don't have transesophageal echocardiogram in this trauma center. We have it in the main trauma center. It's much more difficult to get that option where this patient arrived. And this is what the CT scan showed. She had a significant pulmonary laceration. You can see that picture that represents the pulmonary laceration. She had a few rib fractures on the right side, a few on the left side. She had that displaced manubrium fracture that we talked about. And we x-rayed the extremities, and she had a left wrist and right humerus fracture. Both were closed. The patient was admitted to the ICU, remained completely stable with minimal drainage from the pericardial drain. At that point, we were having about 5 cc's, maybe less than 5 cc's per hour coming out of the pericardial drain, and she was admitted to the ICU. Despite the fact of that impressive CT scan and those impressive injuries, she actually did pretty well and was extubated on trauma post-op day number 2. She went to the operating room with orthopedic surgery. The next day, was extubated after the surgery, and she remained doing well. This is what we did after the patient was admitted and was extubated and with all these injuries. The first thing that we wanted to see was if there's any sort of structural damage to the heart. And just to answer your question, Alex, she remained tachycardic into the low 100s. We never had any sort of arrhythmias or ST segment elevations. But we did a gated CT of the chest that shows a little bit of effusion. That was on the second day after trauma. A little bit of heart strain. I'm going to show you another picture that is very interesting. This is a picture of her heart. And then you can see that both the left ventricle and the right ventricle are filled up. The pulmonary system is filled up. And you can see reflux of the contrast going down both into the SVC and to the IVC. So she had significant right heart strain, no pericardial effusion at that point. We repeated the 2D echoes of the heart, post-op trauma day number 1, a little bit of pericardial effusion. The left ventricular function was normal. We did another one on post-trauma day number 5, a little bit of pericardial effusion, ventricular function was normal. The drainage of the pericardial drain had decreased to about 30 or 50 cc's per day. It was more serious than sanguineous. On post-trauma day number 6, we did another ultrasound of the heart, no pericardial effusion, no pleural effusion, normal heart function. We proceeded to remove the pericardial drain on day number 7. And that day we had about 80 cc's in the last 36 hours, 80 cc's of fluid. The next day we repeated a transthoracic echo that showed no pericardial effusion. Remember, she didn't have the drain at this point. At that point, she got her chest tube removed, went home on post-trauma day number 12. Her injuries were fixed. But just like in those advertisements on the TV, wait, there's more. She returned to the emergency room. And she returned to the emergency room on post-trauma day 26. And this was her complaint. She was complaining of shortness of breath that had developed over the last 5 or 6 days. She was unable to lay down. She had some abdominal pain, food intolerance. She was tachycardic and normotensive. And this is an actual picture of the patient. She had significant JVD on physical exam. And this is the point, the emergency room had performed this x-ray. Look at that bulging pericardium. The cardiac silhouette is in shape is very different from her initial x-rays. The lungs have healed, though. There are no pleural effusions. And we did an ultrasound of the heart. This is an actual ultrasound of her heart. This is at the bedside in the emergency room. I don't know if you were able to see it. Significant amount of fluid, pericardial tamponade physiology, very classic picture. So just to summarize, post-trauma day 26, after what had been a successful hospital time and discharge time, she returns with signs and symptoms and the sonogram consistent with pericardial tamponade. So we can bring the next question, Valeria. The main question here is, you have a patient that you have identified to have a, no, I think there's another question. I think there's a question before that. I'm sorry, the following question probably is probably the following question. All right, this is the question. So this patient had blunt trauma with pericardial tamponade. It's rare, at least in my practice, I've seen in my hands, this is the second time. We get like maybe a couple of years at most. And you have found that this patient actually has a recurrence of the pericardial tamponade on post-trauma day 26. So I'm thinking that some of those that said maybe she should have got a sternotomy on the first trauma probably have some interesting things to say. I'm gonna leave you guys for the next couple of minutes to answer this question, and in the meantime, Gary, can we go around the room and see if someone has some other opinions while we answer this question?
Very well. Curacao, Dr. Frisbee, please.
Did you leave the window open?
Yes, we leave the window. I usually leave.
Like your mother used to ask you, hey, which one of you left the window open? You know?
Yeah. This window was left open. This window was left open.
Okay.
Gary, we can continue going around the room while we get this question.
Yes, sir. Dr. Calderon? Dr. Varon? See, back to Sao Paulo, please. You're muted, sir. There we go.
Okay, I opened it. Sometimes here I can see, it was seen when you have a service of cardiac surgery, recurrent tamponade of the pericardium can be a cure of cardiac surgery. It's not so uncommon, but for trauma it's usually be uncommon. But it's a pericarditis. Maybe sometimes you can go to, in these situations, I believe is sometimes if you put a needle in the pericardium, may be damaged because there is some adhesions of the pericardium with the heart, and sometimes you can be puncturing the heart when you do this by punction or through this. In these situations, I believe that patients need to go to OR to realize the hemopericardium, and then they can be go maybe a good techniques to do in these situations.
Thank you, Dr. Calais. In Rio de Janeiro, Dr. Holanda? Dr. Holanda? Portland, Dr. Kasim. You're muted, sir. I'm sorry, Dr. Kasim, you're muted.
Sorry.
Good.
Dr. Ruiz, sir, remember when you showed some videos of the patient when she was initially in the hospital, you mentioned there was reflux into the SVC as well as IVC. And at that time, I was wondering if the patient had a significant tricuspid incompetence. So now the patient is back with pericardial effusion and jugular venous pressure markedly elevated, and pulse pressure is narrow, and all that, all the parts of Beck's triad. I'm suspicious the patient may have intrinsic heart problems such as tricuspid incompetence along with her effusion in the pericardial sac. So I think I would investigate that with TEE before I resort to taking the patient to the operating room and refer the patient to the cardiac surgeon to see how he can help me. Thank you.
Thank you, Dr. Kasim. Dover, Dr. Alex.
Well, this is a little bit of an unusual. Yeah, I mean, you wouldn't expect that we'll come back like that, the patient. And if there were any, major injury to the right side of the heart, you would have, had problems in the operating room when you open the pericardium, you would have had continuous bleeding. I agree with what has been said so far and all the questions raised. I think probably I would go the route of a pericardial drain, see what kind of fluid is in there, and work this stuff further with a TE and involve a CT surgeon.
Thank you, Dr. Alex. Back to Campinas. Dr. Fraga, your comments, sir. Your mic is on mute, Dr. Fraga. Thank you.
Okay, can you hear me?
Yes, sir. Go ahead, please.
Okay. In my hospital, in this situation, I call the cardiovascular team to consider, discuss with the guys who have more experience in approach to the cardiac injuries like this one. Probably they will do a video sternotomy, go to the OR, and it's a surgical treatment. But you discuss with the specialist.
Thank you, Dr. Fraga. Does anyone have additional comments before we return to Dr. Ruiz? Back to you, Dr. Ruiz.
Thanks, Gary.
Thank you.
A couple of important points that were raised during this discussion. Yes, Dr. Kasim, she had tricuspid regurgitation on the initial 2D echoes. The tricuspid regurgitation did get better and was just a trace on her last 2D echo before she was discharged. Cardiology was contacted at that point and they recommended no further management. The second important point that was raised here, we did talk to the cardiac surgery team. That was the first thing that we did. I think this is a problem that goes, it's a little bit more complex now. This is not just a patient that had blunt cardiac trauma. It's a patient that have an intrinsic, either has an intrinsic cardiac condition or that needs to be taken care of, or something was missed on the first traumatic event. So we spoke to them. And the third point it was that there was the need to perform a procedure quickly on this patient. She was very symptomatic, so there was the need to do something. After conferencing with the cardiac surgeons, this was done over the phone, it was decided to go to the operating room, be prepared to perform a median sternotomy, but start with a percutaneous drainage of the pericardial sac. And the idea behind this was to see if this was an issue of bleeding, unlikely at this point, about a month after, or this was an issue of a pericardial effusion that had accumulated as the result of pericarditis. So we proceeded to go to the operating room. We feel comfortable doing ultrasound pericardial drainage. Besides, this was very, very large. It was really easy to perform through the subxiphoid space. Through the transthoracic space with the ultrasound. So we took her to the operating room, and we did an ultrasound guided pericardiocentesis. This is an actual picture of what we got. It was foul smelling dark blood. It was not fresh blood. It was foul smelling. It was not serous fluid. It was not pus. It was blood, but it looks and it smells like old blood. We washed this out copiously until the fluid came out clear. We conferenced again with the cardiac surgeons, and they said, just leave the drain in place. The foul-smelling dark blood is the hallmark of pericarditis. So we left the drain in place and consulted cardiology, who recommended a 2-week course of colchicine and anti-inflammatories. Obviously, I was very stressed about this situation, having the patient to return to me in Tamponade after a month of seeing this patient and discharging this patient, which what I thought was a success. So we continue following this patient. I followed this patient in person over the next few days. The cultures of the fluid were negative, and that supported more the idea of the patient having a pericarditis. Again, as I said, cardiology was consulted. They provided recommendations. We did transthoracic echoes several days apart, many of them, no effusion. On trauma day 34, the patient got her drain removed. She was completely recovered. I was basically keeping her kidnapped with the excuse of the COVID, but in reality, I wanted to follow this patient closely. And a couple of days later, I sent the patient home. I asked her to get another 2D echo as an outpatient, which she did. I saw her a week after she was discharged, completely fine, no effusion on her pericardium. I saw her after she finished her colchicine and ibuprofen treatment, no effusion, completely recovered, and she came back to get her hardware removed. 2D echo was done during that stay. Nothing in the pericardium. She was discharged home on day 36, and I continued following her for the next 4 weeks or so. A little bit of the discussion on why did we do this not once, but a couple of times of managing a patient with a significant pericardial effusion in a non-operative way, which is not the conservative way to do, which I think is rather the aggressive thing to do, is to not operate on these patients. We know very little. In reviewing what's written, there's very little about it. Most of the stuff that is written is about penetrating trauma. Before the era of the FAST, we used to do pericardial windows. If they were positive, we either do an sternotomy if the patient was stable, or a thoracotomy if the patient was hemodynamically abnormal. However, it's most serious, and this started as a revolution with our first paper in 2011, showed that if the patient had a pericardial window that had stopped draining and the patient was stable, it was safe to avoid the sternotomy and observe these patients with a drain. Many series, 2 or 3 more series have come and have confirmed this. And there's one study, one randomized controlled trial on patients with penetrating traumas that are stable in a positive pericardial window that underwent either to a sternotomy or just drainage. And they had equivalent outcomes without the complications and the length of the stay of the sternotomy. So that's the data we have. Again, it's not a significant conclusive data. These are just a small series of patients or observational studies and just one randomized controlled trial. In one of those papers, I think this is the paper that we published from our institution, basically shows that if the patient is unstable, patient is gonna go to the operating room. If the patient has a positive FAST, the patient is going to have a pericardial window. If the pericardial window is positive and the bleeding stops, the patient remains stable on the last box on the last row, and the transthoracic and the transesophageal echocardiogram shows no effusion. It's safe to leave a pericardial drain. If the patient continues to bleed or becomes unstable, we go for either an sternotomy or a thoracotomy, depending on the hemodynamics of the patient. But this was a blunt trauma. This was not a penetrating trauma. The data on blunt trauma is even more scarce. There's only one series of patients. It shows that only 7 patients had positive pericardial effusions, and 7 were managed operatively, 68 were managed non-operatively. those that receive that were managed without sternotomy receive drainage. Some of them receive drainage, and the most important part of this paper is that any of these patients, any actual cardiac injuries were identified. So if you come to a trauma center with a pericardial effusion after blunt trauma and your hemodynamics are normal, chances are you're not going to have any actual cardiac injury. This is the algorithm from that paper. If the patient, obviously, they won't actually further if the patient has no hypotension or concerning clinical findings. They actually elect to evaluate the patient, to continue to watch the patient. If the patient has some clinical findings that are concerning or hemodynamic problems, they either go for pericardial drainage and or exploration. These are the contributors. As you can see, the first reference is the paper that we published is 2012. Since then, some other papers have come here. And I'm gonna leave the rest of the time, the next 5 minutes that we have or so, to having some conversations. I have here a couple of questions. Did the patient develop fever? She never developed fever, but she did develop an inflammatory syndrome. When she returned to the emergency room, she had both pericardial effusion and ascites. I didn't mention that, but after we drained the pericardium for the second time, we took her for a CT-guided drainage of her ascites, and turned out to be clear fluid, acidic fluid, no cultures were positive. So this was kind of a inflammatory syndrome. And there's another person here that says she developed post-pericardialotomy syndrome. She needs anti-inflammatory. It's a common occurrence. This is actually my first case in which I see a return to the operating room for this syndrome. I know it has occurred, especially in cardiac surgery. It's well described. I've never seen it happening in trauma, at least not in my practice. And after the initial presentation, where she had the first pericardial window, we didn't treat her with NSAIDs because there was significant trauma. So we elected not to give her NSAIDs at that point. She was treated with NSAIDs and colchicine on her second presentation. And I'm gonna leave Gary to go around the room to see if there's any other discussions, any other opinions, or any other interventions. And I thank you very much for being here today.
Thank you, Dr. Ruiz. Portland, Dr. Kasim, your final comments, please.
Well, this sort of things are quite common in the underdeveloped countries, and the patient sometimes have tuberculosis. And I've heard of that from my friends who practice in India. But occurring in a place like Miami, post-pericardiotomy syndrome most likely is due to virus, and it is very hard to diagnose, very hard to culture, very hard to elucidate, but there is literature showing that Coxsackie virus sometimes give rise to post-pericardiotomy syndrome like you have had. But still, I think you have managed this case exemplarily, and it is a very good educational morning for me. Thank you.
Thank you, Dr. Kasim. And Sao Paulo, Dr. Clay, your final comments, sir?
Yes, I have to congratulate for the case. It's a very important case. I believe that pericardial infusion in trauma patients is sometimes we have doubts what to do. It's very clear for me that the patient is stable, it can observe. If the patient is unstable, maybe unstable, you can go to a pericardial window and then go on other procedures. You can treat all the pericardial infusions, size hemopericardium. I see there is a large cases, many cases in the Colombia that they try to penetrate trauma in the heart or penetrate trauma in the pericardium conservatorily, and maybe open the pericardial window, then infuse fluid if the patient is stable, And then if the patient continues stable, the fluids not return more blood, they can put a drain and observe. It's usually done in some parts of the Colombia. Here in Brazil, I don't do this, but I have to go to all the patients to go to the to see what's happening is unstable. Thank you for the presentations. It's very important to see what the presentation. Thank you very much.
Thank you very much, Dr. Calais. And Dover, Dr. Alex, your final comment, sir.
This was another educational opportunity for us. Thank you, Gabe, for presenting this case. I don't have really anything to add. Only one thought with regards to these hemorrhagic effusions with pericarditis sometimes are seen in dialysis patients due to uremia. But from what you presented, it doesn't sound like she had any issues with her kidneys, and she wasn't, hypotensive to, get to a point where this may be a cause. Thank you. Great case again.
Thank you, Dr. Alex. And Campinas, Dr. Fraga, you have final comments, sir?
Excellent case. Congratulations.
Thank you, Dr. Fraga. Dr. Rubin, you have comments, sir?
Thank you, Gabriel. A very great case, but I know you see it in penetrating injury and post-pericardiotomy syndrome. You see those cases, and doesn't, not all of them, they come with fever, but they come with inflammatory pictures. And, the best way probably to do it will be, NSAID and so forth. This is a great case. I like the protocol from Miami. Most of the people probably will not do that. If I have this liquid, probably I will go from the pericardiotomy syndrome and I check the heart myself. Thank you.
Thank you, Dr. Rubin. Dr. Hakim, your comments, sir?
Thank you. Just wanted to ask you retrospectively, if this patient would have undergone a drainage of the pericardium in the initial presentation, and then gone to the CT to avoid that laparotomy, because that laparotomy must have taken 15 to 20 minutes, and probably that would be the time taken in the CT. And the patient had actually become stabilized by that time. I mean, would it have been an alternate pathway to avoid a laparotomy and the morbidities associated with that?
Was that a question for Dr. Ruiz?
Yes.
Dr. Ruiz, yeah, Dr. Ruiz.
Yes, I totally agree with you, and I think it's a great contribution. That would have been another option, and after the fact, once we sat down and discussed this case with the rest of my colleagues, this is one of the ideas that came out. Perhaps after having stabilized the patient and knowing that the patient was completely stable, I could have gone to CT and avoided laparotomy. Certainly, and I tell you now, looking in retrospect, that laparotomy would have not been needed. She had a grade 1 liver laceration that didn't really need anything.
Thank you.
Thank you, Dr. Hakim. Dr. Andrade? You're muted, sir. There you go. Thank you.
Yes, hello.
Go ahead.
No, I just was a very excellent case presentation. I am not doing that many trauma now, but I used to do a lot of trauma, penetrating mainly penetrating trauma and cardiac trauma. And I have seen a couple of these Dressler syndromes that, yes, we treat with drainage, mainly by pericardial aspiration, leaving the small tube, and anti-inflammatory. The other thing that I can bring to discussion here is that sometimes I think we can do pericardioscopy, and we have done it 1 or 2 times, and has been very useful as we can be able to see immediately if we can see an injury in the heart or the pericardium. So it's open to discussion.
Thank you, sir. We're gonna reserve the ultimate last comment for Dr. Marttos, but before that, let me just ask if anyone else has a comment before Dr. Marttos.
Yeah, I just want to add in one thing, if you don't mind.
Go ahead, please.
Yeah, so is it a take-home message for all of us here that once we discharge a patient of a pericardial collection due to trauma, where we have not found out the actual cause of that bleeding, that we call them preventively as a follow-up, to do a follow-up ultrasound just to evaluate the pericardial cavity?
I'm sorry, that was for Dr. Ruiz?
It's actually for all of us as a take-home message to preventively do an ultrasound in the follow-up period to prevent that patient reaching a stage of a pericardial tamponade.
Good idea.
Thank you, Dr. Hakeem. Thank you for your comment. And,
I certainly think it's a good idea. I have to make one comment for Dr. Marttos. When we talked to the cardiac surgeons, it was impressive to me how routine this was for them. They looked at the case and they said, "Don't worry about it. Just put a drain, put it in the ICU, start on some anti-inflammatories. She'll be fine." I was stressed out about the fact that I had this return on this patient. And again, as I said, I used the COVID pandemic to keep her in the hospital longer than I needed to, probably. But for them, it seemed to be a routine finding, and they do this more than we do. So perhaps they see much more occurrence of these cases.
thank you, Dr. Ruiz. And Dr. Marttos, would you like to close the session, please?
Yeah, so
Go ahead, please.
So thank you very much, Dr. Ruiz. Great presentation. I had a similar case 3 months ago, blunt trauma, then pericardial effusion on the fast ultrasound, patient stable. I did pericardial window, a little bit of blood came from there, but not much continued came. I left like a drain. I did the echoes for post-operatively, and the patient did it fine. I would follow up with another echo once the patient come back to clinic. I believe that again, the trauma surgeon are not used to do this. We see positive fast, we go to surgery, but sometimes if you are the right place, you have research, you have how to follow the patients, you can do some different management. Like Dr. Ruiz said, the cardiac surgeons, they do this all the time, so we are learning how to manage this kind of situation that is aggressive. I would like to finish this conference today honoring Dr. Alberto Basilio Olivares. Dr. Olivares left us today, a great member from the Pan-American Society, a great surgeon, well known every single country in Latin America. And I will just read some words from Dr. Aurelio Rodriguez. He sent it at the Pan-American Trauma Society group today. Alberto era parte de la familia de trauma en Latinoamérica y su partida es irrepresable. Sin embargo, su obra como maestro da cirugía del trauma quedará como un legado para siempre. Vive sempre em nossos corazones, Alberto.
Antonio, let me translate that. Let me translate that. Alberto was part of a family of trauma in Latin America, and him living is irreplaceable. However, his work as a master of surgery of trauma will live forever. He will live forever in our hearts.
Okay, so just I would like to finish this with a minute of silence in honoring Dr. Basilio. On Wednesday webinar, we're gonna make an honor to him also COVID-19. So around 1:55 p.m. I'd like everybody to join. So everybody has some pictures and some words to say to Dr. Basilio. Saying these pictures and words to website, okay, or to Dr. Valeria, or to Valeria, or to myself, or to the Pan-American website, WhatsApp page group. Then you're going to honor him at the end of the webinar on Wednesday, okay? Thank you very much, everybody. Stay safe.